Welcome to Doctors Coy
D and Rachel F. Fitch, the seventh endowed lecture in medical leadership. Here we have Dr. Fitch with Dr. Rachel Fitch. Dr. Fitch was our chairman of internal medicine from
1985 to 2000, and I had a great pleasure of rotating with him for all 31 days in December. That's when attendings did a 31-day shift. And we have a lot of residents, former chief residents of Dr. and students of Dr. Fitch here. And Dr. Albert is right here. He's one of them. And he inspired generations of physicians during his 33-year tenure at St. Louis University School of Medicine. His service to St. Louis University began in 1967. He started as associate professor of internal medicine and biochemistry. And he was the founding division director of endocrinology. And his vision focused on providing superior care and treating patients with respect. And he was intensely focused on making the Department of Medicine one of the best institutions or best departments in the country. He recruited some of our iconic division directors like Drs. Bruce Bacon, Bob Belchie, Kevin Martin, and John Morley at that time. And that actually put us in the national map. Here is Dr. Rachel Fitch. I knew her well too. And Dr. Fitch and his wife, they shared a common interest in improving the practice of healthcare and increasing its access, availability or access. Dr. Rachel Fitch spent many years working through political systems, both at state and national levels, to establish healthcare policies to improve access to healthcare for individuals at all socioeconomic levels. This is the picture I have shared during the previous Dr. Fitch lecture. It's also to tell my pulmonary critical care colleagues that I had a head full of black hair and before I met all of them. And this was in 1996 when I was second-year resident, presenting to Dr. Fitch my poster on lung transplantation at Lake of Ozarks. And he was the governor of American College of Physicians of the state of Missouri at that time. And Dr. Rachel Fitch took this picture, and Dr. Fitch sent me this picture through mail with his handwritten note. And he also used to send annual holiday/Christmas card to all the residents who rotated with him for many years. So I received it for a long time. So this lectureship has been made possible by the generous contributions of Dr. Fitch family. Thanks to Julia Fitch Brown, Robert Brown, Dr. Jacqueline Fitch Frankenstein. She's the GI physician at Washington University. James Frankenstein, his faculty in infectious disease at Washington University, and granddaughters Meredith Noto, Carol Brown, Margaret Hams, and Katie Frankenstein. Many of former students, residents, fellows, and faculty have contributed generously to this endowed lectureship, and it has reached the level of endowed lecture. Is you have to hit certain financial mark, and this will live on in for perpetuity within the Department of Internal Medicine. We have had six lectures so far. Our former chair, Dr. Adrian DiBiscelli, was the first speaker. In 2012, I had the pleasure of attending that one. Dr. Miller, also former chair, did the second lecture. Now, today we have the pleasure of having Dr. Daniel Brennan as our seventh speaker for this lectureship series. And this is my pleasure to invite Dr. Lentine to the podium. I have to tell you, everything you see today is done by her. Anything is wrong, you can blame me for that. All the credit of this successful lectureship and Dr. Brennan's visit, all the credit goes to Dr. Lentine and the team.
Thank you very much, Dr. Nayak. And before getting into our content, we'd like to thank our additional event supporters, including Amanda Sane and the St. Louis University CME office. Mid-America Transplant as our lead lunch sponsor, along with SSM Health Transplant and the National Kidney Foundation. And thank you so much for your support of our event. And of course, Gloria and Haley for all the organizational work to help make this happen. So I am deeply honored to introduce our invited speaker for the 2024 Fitch Endowed Lecture in Medical Leadership. And as Dr. Nayak described, this endowed lecture is a highlight of our excellent conference series. And our guests are chosen from amongst the most influential in the country. And we want to thank our attendees who are joining both in person and virtually. And again, thank the Fitch family for the generous gift that has supported this event. And when Dr. Nayak gave me the opportunity to invite a professor who represented the triple threat in academic medicine, I had no question of who I hoped would join us. And as this lecture progresses, I think that you will clearly understand why. It's a true pleasure to welcome Dr. Daniel Brennan to St. Louis University. Dr. Brennan is professor of medicine and medical director of the Comprehensive Transplant Institute at Johns Hopkins in Baltimore, Maryland. Dan has been a leader at Johns Hopkins for the past 8 years, but previously spent more than 2 decades building the kidney transplantation program at Washington University, and his deep roots in the Midwest, as we will see in a moment.
Suck it in, Scott.
Dan was introduced to medical science at an early age, as his mother was an immunologist, and at some level, Dan notes that he has been thinking about medicine since his infancy. He has a love of science since grade school, and shown here is one of his first scientific poster presentations, a winning exhibit at the 7th grade science fair in his home city of Chicago. Dan attended college and medical school in Iowa, forming friendships that have lasted a lifetime, including with Dr. Lawrence Kinsella, who has joined us today. Dan then went on to medical residency at University of Iowa, and I believe overlapping with our own Dr. Dan Hunt, followed by nephrology fellowship and transplant fellowship at the Brigham and Women's Harvard Hospital in Boston. He did a short period of private practice and then worked a first year as a transplant attending at the University of Nebraska. In 1993, Dr. Brennan moved to Washington University in St. Louis, where he's had a highly productive period of service. His titles are prolific and include appointments and recognitions as the Director of Transplant Nephrology for 24 years, building the program literally from scratch into one of the largest in the country. Was co-director of the WashU Translational Research Corps and received an endowed professorship. And then Dr. Brennan was recruited to Johns Hopkins in 2017 to serve as the medical co-director of the Transplant Center. And while the kidney remains Dan's favorite organ, he now oversees transplant service lines across all organs, including vascular composite allograft, as we'll hear about in Dan is a very gifted teacher, and whether at the podium or the bedside, he has taught hundreds of nephrologists, internist surgeons, and pharmacists over his career. He's passionate about the art of medicine, and to this day, I still see patients in St. Louis who remember the care that Dr. Brennan provided both for them and their families. He's also a sought-after speaker and gives lectures in immunosuppression and transplant-related care across the world. And as a true triple threat, Dr. Brennan is a prolific researcher with a history of robust National Institutes of Health, foundation, and industry funding for a broad portfolio of clinical trials that have really shaped the standard of immunosuppression and antiviral prophylaxis. He served as an editor of leading journals, including service on some leading journals in transplantation, and was one of the original nephrology editors for Up to Date. And he has received recognitions from numerous professional societies, including the National Kidney Foundation in St. Louis, as shown here, as well as the American Society of Transplantation. And finally, a notable dimension of Dan is his successful balance of personal and professional life. He's a devoted husband, father, and grandfather, and he'll share more about his family in discussing his journey. But his friends always enjoy hearing and seeing photos from his family vacations, documenting all the fun activities that they enjoyed together. And last but not least, mentorship has been a cornerstone of Dr. Brennan's career. I was fortunate to work with Dr. Brennan as a fellow when I first moved to St. Louis and to build a productive collaboration that has spanned many publications, grants over many years. And it was a tremendous honor for Dan to serve as my mentor at my induction at the American Society of Clinical Investigation last year. And in fact, Dan has mentored countless physicians and scientists, imparting knowledge, but also a true love for both the art and the science of medicine. I'll close quoting some words to live and work by, adapted from concepts that Dan has taught me over the years. Do what you can for the most. Never forget to smile. Work for the greater glory of God. Do the right thing. There are but three things that last: faith, hope, and love. And the greatest of these is love. Welcome to SLU, Dr. Brennan.
Wow. Thank you, Krista. Thank you to the sponsors. Thank you to the Fitch family. And it's really a pleasure to be back in St. Louis. Someone asked me, where's home? And I didn't know where home is. But St. Louis is probably one of it. It's probably as close to home as there can be. So I'm going to talk about this. Krista has an attention to detail. This might be the fourth or fifth version of the title that Krista finally was satisfied with. So these are my my financial relationships, I think is the term we use now. This is Coy D. Fitch. So I'll just read this to you because I looked him up on the internet. And this was kind of important to me because the person who wrote this is Gus Schoenfeld. Gus Schoenfeld was the head of medicine briefly at Washington, endocrinologist. And he was a Nazi camp survivor. And he said some interesting things to me that really helped me early in my career. And so, but this is what he said about Coy D. Fitch. More interesting and perhaps more important aspects of Coy's character emerge from the Coy Fitch stories that are circulated about him by friends and colleagues, which attest to his high native intelligence, determination to get things done, generosity of spirit, dry humor, fairness, and devotion to his students' profession and institution. All of us contribute to our institution, some more, some less. Coy's contribution was very large and will continue to be felt for a very long time. So I think Ravi last night, hearing more about him and hearing from one of his mentees, I mean, can it get much better than that? I mean, I know my epitaph is going to say, stop the MMF. I'm hoping that Krista can actually write my epitaph because there are some notable publications that he's had. When I'm reading about these, I'm looking at this. Okay, Dinnings, Fitch, influenced vitamin, rabbit. Now that's interesting. Rabbit, thymoglobulin. Okay. Fitch, creatinine. Okay, Fitch, creatinine, Fitch. Production, creatinine. Janie Fitch, G6PD, malaria. Okay, well, maybe. Okay. Oh, ApoL1, that fits. Fitch, chloroquine. Oh, yeah. Krista and I have a paper looking at hydroxychloroquine for the substitution for, guess what, MMF in transplantation. So I realized that this guy was an endocrinologist trying to be a nephrologist, right? So I think we have that in common. So the objectives of this synergized strategies to build a successful academic career. I'm going to tell you mostly about my experience because I don't really have the answers. So I'll just tell you what it did, what worked for me. And as I always tell my students, if you can take anything from me, take it. If it's bad, don't take it. So if I say anything offensive, don't take it. Okay? 2, describe how to leverage key resources in professional societies to promote academic success. And 3, state the importance of balancing. Just when I was putting the finishing touches on this, I had learned a new way of approaching this, and I actually kind of like it. Most new stuff I don't like. So, but this is integrating personal and professional goals and sustaining a durable and well-rounded academic practice. These are some quotations that I really like. You've seen some that I've others that I've quoted. Krista quoted some of those. This is one I really like. This is from Osler. To study the phenomena of disease without books is to sail an uncharted sea, while to study books without patience is to go to sea at all. And this is a brief story. When I was a second-year medical student, I got to tell you, I hated the first 2 years of medical school. I hated it with a purple passion. When am I going to get to see patients? During your second year, they have people come in and role play as patients. That didn't work. Towards the very end, it's a hot day, spring day in Iowa City, and the psychiatrist brought in a patient on the platform there, the stage. And it was this guy who had been arrested in Iowa City for driving his purple Corvette 75 miles an hour in a 35 mile an hour zone and claiming to be a writer of Ray Charles songs. And so they immediately locked him up for being a delusional schizophrenic. And so he was also kind of bipolar and had depressive speech, and he was talking a mile a minute. And then the young psychiatry, probably resident, I'm a second year student, said, and he's got this really long hair, and he said, so is there anything, Mr. Holliday, you would do for these, to say to these young doctors to be? And he looks out at us and he says, he's talking really fast, and he says, how now, brown cow? Kind of slowing himself down, and then he stops and he looks right out at us and he says, you got to do it for us. And suddenly I became a gunner. That's when it started. I read everything I could. I worked nights and weekends because you know what? I wasn't doing this for me. I had been. I wanted to get in med school. I got good grades to get in med school. This changed my life. I was not doing this for me. Out of the voice of the crazy people, right? I was at WashU, and I had CJ Zhang. He was a fellow with me, PhD. We were walking over to clinic. CJ turned out was really, really depressed. I didn't know it that day, but he was really depressed. I wasn't having a good day, and I said, CJ, we're walking over to clinic. You know what? Every one of our patients has kidney failure. Every single one of them. You don't. I don't. We probably never will. We're lucky. I looked up CJ because he's a big wig now at Kaiser Permanente. And his quotation is, the greatest joy of being a doctor is having the ability to help people. I could almost stop here. But I'll start at the beginning instead. So what I started to do after that was in medical school, we had to memorize stuff. We didn't have these thing called computers that gave us the normal values. So you had to write them down and memorize them. And you can see early Parkinson's micrographia. If you can see there, it's the cholesterol level. Now, remember, this was Iowa. So the normal level was 150 to 300. They lived forever. So you know what I think of cholesterol? Not much. I do think exercise is good. You got to walk the mile down to your mailbox. The other thing I'm going to harp on this was I had a great teacher in Richard Wenzel. He exposed me to this, the how to read the clinical medicine. And it's small, but those are the first four things. So I had this, I wrote down everything just to try and remember it. And little did I know, by the way, I hated nephrology. Could not learn physiology to save my soul. Sorry, Bob. So what happened is, there's a great mnemonic. I was sitting in a grand rounds, very boring, next to John Gottschall, great guy, became a pulmonologist. And this is one of my first early mnemonics. I love mnemonics. So it's how does contrast nephropathy? C is for CHF, old age, N, nephrotoxins, T, too much dye. You got to make it work. R is for renal insufficiency, A is for amyloid, S is for sugar diabetes, and T is if you are too dry. And then below that is dialysis formula. And who knows? Then the acute peritoneal dialysis, and then the types of dialysate. You know, I'm taking the long-term knowledge assessment right now. I am smoking the dialysis sections because it hasn't changed in 35 years. It's my routine. So I wake up and the four S's, won't dwell on that very much longer. I pray, I meditate. Gratitude. St. Ignatius, here we are at St. Louis University, said ingratitude is the greatest sin. I totally believe that. When I'm in a funk, I go to the Reimagining the Exam, and it's an app. I recommend it. And I go to the gratitude because praying for someone else, thinking of all the blessings that I have, really helps. I exercise. I've been an exercise fanatic all my life. At one time, I was going to go back to Iowa as a family practitioner. Instead of going out for a drink, we are going to go out for a run. Didn't happen. I became a transplant nephrologist. Actually, I'm a left upper pole transplant nephrologist. We get very specialized. I do Duolingo on the stationary bike. I've got over 1,800 days of Italian. I can say ciao bella. So breakfast is the best meal of the day. Email. Thank you, by the way, for Krista for accommodating me. We went to the Kingside Diner. Well, excellent. I go to meetings. I go to lots of meetings. There's a story about the grounds that there's the dome in Hopkins. That's where the patients were. It's a wonderful story, and Osler would go around and make rounds, and that's where they come from. It's totally untrue. And only like last year, they put up a little plaque saying this is untrue. It's like, why? Why tell you? I mean, and you're probably going to tell me there's no Santa Claus. So, email, epic. Read the journals, lunch at the desk, epic, email, meetings, round, clinic. Bike, when I get home, dinner, Duolingo. Write, read, research, watch baseball usually, like baseball. Love the Cardinals. What happened? And read the examen. So, reimagining the examen. Rules to live by, pre-coaching. This is what I did. So pre-coaching. So I've been through executive coaching twice. I think it's good for everyone. Probably need a third time. So do it, ditch it, delegate it. So with extra coaching, I added deliberate appropriately because I used to not deliberate. I just got things done. You get things done, but you make mistakes. Donuts. Love donuts. Round one coaching, stimulus, response, intent, impact. So I went to Hopkins. I walked in there. They transplant, they measure you by stars or bars. They were at a 2 bar out of 5. And I put up the slide showing the UNOS. I said, by the way, WashU, we were 5, 4 or 5. We slipped. I think you're back up to 5. I think that's 5. So I went to Hopkins. We were at 2 bar. I said, you know what? Sorry, Krista, Hopkins sucks. You know what they heard? Hopkins sucks. You know what they listened to the rest of my lecture? Absolutely nothing. So I had immediately dug myself a deep hole early on. I was just you can't solve a problem if you don't see that you've got a problem. Didn't matter. My intent was to point out the problem. Let's focus, work together, team, go fix it. The impact was very different from what I said. Like coach taught me whiff them, and it's what's in it for me, but it's not. It's what's in it for everyone. I just learned this. You may be right. What a great thing. I'm arguing with someone. You may be right. In my mind, I'm thinking, are you crazy? You may be right. Then I had a mentor. She died with 4 cancers. What would Terry Langbaum do? So she was dying, and I said, she didn't show up for work, and she loved to work. And I said, Terry, what am I going to do without you? You know, I just came to this job. I can't do it. And she said, and it's important, she said, guide with compassion and integrity. So I'm making a tough decision about a transplant patient. Do we transplant him or not? I really try and focus on it. Am I doing it? Round 2 coaching. Big thing I learned. Wait. Why am I talking? Why am I talking? Why am I talking? See, there's different ways of saying it. That's been very useful to me. Another thing, you probably know this. Does it need to be said? Does it need to be said right now? And does it need to be said by me? I can't tell you how many times this has been useful in the past year. Don Miguel Ruiz, Toltec Wisdom, my coach said this. He said, don't read this. It's full of a lot of stuff that's absolutely worthless. But these are the 4 agreements. Be impeccable in your speech. And it doesn't mean swearing. It means basically don't gossip. Don't talk bad about people. Don't take things personally or Q-tip like that one. That's hard. You know, when people are trying to make you feel bad, they're trying to make you feel bad. And you do feel bad. So that was a psychiatrist. You want to know what the diagnosis is? How do you feel after you're talking to that patient? Do you feel confused? Feel really excited and really depressed? Well, you can tell what the diagnosis is. Don't make assumptions. Always do your best. There it is. Ad majorem Dei glorum. And look at it from the other person's perspective. So, and I screwed this up, but let's look at this here. This is my perspective. This is true, right? 1 + x = 9. No, it's wrong. You're wrong. You can't even agree on the most fundamental principles. Stop wasting each other's time. I've got things to do, places to go, people to see. Turn it around. On the other side of the table, what does the person you're arguing with see? Whoops. Oops. Look at it from a different perspective. I really try and do that. Probably don't succeed. Getting back to how to do clinical research, Krista knows I've kept a list for many years of how to do stuff. And so things that I've figured out, Krista used to turn to me and say, do you have a model for this? And she was an inspiration for me to do when something came up. That's how I teach. I've developed models for others to use. I've been through this. You don't have to do everything yourself. This is why I do. It's gotten me in trouble. It's like, I've done the research. I know how to do this. Just listen to me. But keep a list of questions to answer in future research. When they were trying to recruit me back at Iowa, I finished my talk, brilliant talk. What's your next project? I didn't have one. I was 32 years old. I was running out of ideas. Okay, I'm going to private practice, which I did. Then I ended up working with a bunch of surgeons, wonderful people. They've got a can-do attitude. It wasn't a bunch of medicine guys sitting around thinking, plotting, plan, and get nothing done, right? There's a joke about that. I can tell that later. It's PC. But find a good mentor. I cannot tell you how important that is. And hopefully it'll be a mentor who's a life coach. I found one at SLU not SLU. Where am I? At Wash U and Greg Storch. So he was life coach. Be a good mentor and collaborator. Take a stats course. Learn how to do your own basic stats. Sample size and power, parametric, non-parametric, life table, and survival analysis, and KM graphs. That's about all I can do. Then the key thing is actually collaborate with people who like this and know what they're doing. Learn how to use EndNote. When EndNote first came out, I was a fellow in Boston. I learned how to do it, and then I haven't used it in years because other people learned how to do it. But I still recommend it as something to do. Subscribe to a literature search service. This has been very useful for me. Learn to read the clinical literature. We're going to go over that in a little detail. This is the first 10 things on my list because when I walked away from Iowa, I thought, I'm terrible. What can I do? So I had from the VA a little green book. It was made of paper, and I started writing out ideas. The first one is hyperkalemia and parathyroidectomy. This was 1992. In about 2020, the Chinese published on this. And so I never got around to it. OG, that's not old guy. That could be old guy, but it's not. It's cyclosporin OG. Now we know that maybe sort of as voclosporin. Knee oral, that's the new cyclosporin. CMV and HUSTTP. So where's video? So there you are. So same thing. So I started paying attention to this very on. CMV and HUS, two of the things that I was really interested in. Wrote this up. Didn't pay attention. One of the few times I wasn't as oral OCD as I should have been. The paper was turned in. They rejected it. It was horrible. I read it. I hadn't looked at the final version. Never do that. So endothelin and nitrous oxide for rejection with cyclo, TH1 and TH2 subsets. RS, you know what RS is? It's Roche syntax. It's mycophenolate. So it blocks IMPDH. It's synergy with acyclovir for blocking DNA, or polymerase for guanosine. So I thought there would be a role for it in CMV. That was wrong. Sickle cell. DIC, CMV. So those were that started it. These are the types of clinical research, and this is what I tell, and my people come to me, and we can start. So the first thing is a case report and review of the literature. You're seeing something all the time, something that someone hasn't seen. Write it down, go to the literature. You know what you've got that I didn't have? You've got computers. You got to search the web for all kinds of things. I had to go to a library. It's a big building where they have books. And there's a thing, it's called a card catalog. And it was wooden. And there were like files, cardexes. That took a long time. You can answer this, and they are. I think of a question on rounds, and I tell them, the way I enjoy teaching and the way I stay in this business is you teach me. That's the way it works. They have the answer in seconds because they're on their phone looking it up. How do you know that? Well, it's right there. Well, it's amazing. Do a systemic review of the literature and meta-analyses. Do outcomes research. These are the easiest thing. And then clinical trials. I'm not going to talk about basic science research, but I really think that's the way to go because that's what I did. And if it weren't the right way to go, I wouldn't have done it. So there's industry-sponsored research there's investigator-initiated research. The sponsor means who's responsible for doing all the legal and according to the FDA, et cetera. So I like it when I have an idea and I get the industry to pay for it. That tends to work out. NIH-sponsored research, it's very useful. You get effort and stuff like that, but boy, it's the government, right? So not known for its efficiency. Clinical trials are extremely important when performed right because they are in the right animal model. I don't have to assume that something that happened in a NZBW mouse for lupus is going to translate into something for a human. I just showed that the Plaquenil is useful to prevent recurrent lupus. They advance our knowledge. They help discriminate useful from non-useful therapies, diagnostic tests, biomarkers. They improve clinical care, usually, and they can be a springboard for a career. I hope it will work for you. It did work for me. What does an industry-sponsored research do, though? So it gets you familiar with the design and implementation of a clinical trial. We talked about Elisa, about the doing your own IND. You learn how to do that. Turns out that the IND is the least of your impediments to getting stuff done. You submit it to, and it was the biggest fear for me, but you do it, you submit it, they have 30 days to say yes, no, or maybe, and they do. And usually it's pretty good. You review the proposal for a scientific merit, you write and submit proposals. There's an act of learning just in writing stuff down. You learn the importance of adhering to a protocol, obtaining good data collection, and realizing when you get the importance of meticulous records. You learn how to help in the analysis and the study and the writing and the presentation of the results. You build collaborative networks. You go to the investigator meetings and meet people. You talk about it. You give your results, and it's wonderful. Industry-sponsored research is the investigator gets to design and perform the trial. That's really is useful because it was what was interesting to you. Now the challenge is to get what's interesting to you to be interested to someone, and interested to someone who has what you want. That something is a drug, it's a device, it's something, and you got to get them fired up about it and think that it's worthwhile. But you are the one filing the FDA IND. You are the one filing the 1572, which is the form for who's doing the research. You are doing all the IRB work. Industry contracts want a deliverable. The thing is, usually payment is based on certain milestones. As long as you deliver milestones, you get paid. You don't get paid. That's easy to understand. If you run out of money, you go back to them and ask for more money. Or sometimes they see, wow, that's great stuff. We'll give you more money to keep it going. So that's what's nice about that. And with the leftover money, you give that, you put that in the bank, and you use to support fellows, to buy computers, to go to meetings. That's what's lovely about it. NIH-sponsored research, you usually reply to a response to an RFA. Krista mentioned my mom was a PhD immunologist and microbiologist. She said to me, Danny, never respond to an RFA. They've already decided who's getting the money. Okay? So don't bother. Actually, I did get an RFA with Krista, the Apollo grant. So you're wrong. She also said when she'd been out of the business for a while, what do I wear? Clothes? to an NIH study review. And then she came back and said, Danny, I have never met a more mean-spirited group of people. Why are they so mean? That's a pie, it's about this big, and everyone's fighting for that little bit of money. And Dan, you probably know that. Studies like grants allow you to entry and then regroup. That's a weird thing, right? You apply for the RFA, you write the grant, and then they get the next year, they spend the next year rewriting it. That was weird for me to understand that. Many problems typical of working with the governments are its inefficiency, it's under budget, it takes too long, and you have to spend the unspent money on stuff you don't need. The investigator effort does a cap at $200,000. So at WashU, they asked the surgeons not to apply for the K grants because you'd get 50% or it was 75% at a time for a K grant support for a salary that's way beneath what they did. So someone has to pay for that. That someone is your department, your division. The FNA is it differs. I don't understand how it differs. I think someone said 35% at SLU. It was around 60% at WashU. It's 62%, I think, at Hopkins. It was like over 90% at Stanford. quite get that, but I've never understood California. So industry-sponsored research for the new investigators starts with an idea or question. Again, going back to the beginning, write it down. Does someone know about it? Go to the literature. Did someone write about it? Is the question important? Would anybody care? Has anyone tried to answer it before? Does it need funding? How much funding? Can I get the funding? Who would fund it? These are some of the simple questions that you do. But I'll show you, it's been worth it for me to do that. Follow that by a literature research. Jokingly, I would say, do you read German? Do you read Japanese? Now I'd say, do you read Chinese? Have they done it? Because oftentimes, someone came to me about looking at the use of spironolactone in dialysis patients. Why would I want to do that? They don't pee. Is it going to cause hyperkalemia? And it was a junior faculty at WashU, and I said, did you do a literature search? And guess what? Yeah, the Germans had done this like 20 years ago. They'd already investigated it. Write it up like a grant. And these are simple. There's a specific aim. There's a hypothesis, a background, and methods. Do that. It gets you organized. Present it to someone. Present it at a research meeting. It organizes you. Develop a PowerPoint slide. So when my daughter got married, in fact, I was asked to do the father of the bride speech, right? So I got up there. First slide, please. I actually didn't have a PowerPoint presentation, but I did have notes and I did have an outline. And those are key. Involve collaborators, including both clinical and basic science. I've always tried to do that. Now we're going to look at the rules for reading the journals. These first 4 rules are critical. Look at the title. Is it interesting or useful? If it's not, stop. Now, there's a joke. How do you keep internists out of a code? You put a journal articles out in front of the table outside the room, so stop to read it. Well, that's essentially me too. So I had to break myself of this habit. Is the title interesting? It's not interesting. I don't really care about this thing. Stop reading. But so review the list of authors. Do you know them? Are they honest? Do they have a good track record? Read the summary. If the conclusion were valid, would it be useful in my population? Consider the site. Is the site sufficiently similar to your own? Is your access to the required facilities good? Are the patients seen? So this is the one of the studies that Richard Wenzel used to teach us how to read the clinical literature. It's called the 4S study, which was the beginning. I talked about the 4 S's, which, by the way, I think Krista is 4S, right? Stanford kindergarten, Stanford undergrad, Stanford residency, internship, fellowship, and then she came to SLU, so she can't get away from the S thing. So this was a randomized, double-blind, placebo-controlled trial. Right away, it's looking good, looking good. And what I let 4S of, oh, this is good. 4,444 Scandinavian men. Okay, stop. Don't need to read any further. I will never treat actually, there were a few women. I will never treat 444,000 Scandinavians. I'll probably never treat 10 Scandinavians. I could probably stop. But this is the whole idea with cholesterol. Again, why did I focus about cholesterol on that thing? Because it comes back. It comes back. 305 is not what they were targeting. So looking at 3,600 men, 800 women, they stopped it after 5.4 years of median follow-up because of a 3.3% absolute risk reduction in all-cause mortality. The essence of education is repetition because of a 3.3% absolute risk reduction in all-cause mortality. The essence of education is repetition. Really? 3.3%? Absolute? Of course, it was the magical 33% relative reduction, which makes everything get approved. So if you looked at that and looked at the number needed to treat, okay, 30, and that p-value, wow, that's a lot of zeros. Reductions in the multiple other endpoints, including major coronary event, 15, cardiovascular mortality. Then the medication was overall tolerated, right? It's simvastatin. Then they did a post-hoc analysis. This was sponsored by Merck, okay? Randomized trial, Lancet, 1994. This is showing the differences. You can look at especially the early on in the first 1 year, see how the curves are going together. They separate. There was no difference in the first 1 to 3 years. The early difference in secondary MI were four events in the simvastatin group, 6 in the placebo group. Was that a trope leak or was that a real MI? This study led to recommendations around the world about using cholesterol for the secondary cholesterol lowering agents, statins, for the secondary prevention. And when you actually look at the data, wow, amazing. So when you get a significant result of something small, it could be a type 1 error, it could be really significant. Another thing that's certainly taught Merck, you have to be patient. We're in the Apollo trial. What are we in? Year 12, something like that? I think we're in year 7. Unbelievable. People get tired. So how has this worked out for me? Well, thymoglobulin was a rabbit antibody. It was used, developed in France. And I was in a trial where we used it for prevention, for treatment of rejection compared to ATGAM, a horse preparation. I enrolled one patient. One patient. Because you had to get OKT3. That's an old drug, shake and bake. It was horrible. So the nurse coordinator said, Dr. Brennan, stop. This is a horrible drug. We're not going to let you do this. So I did. But I went to the company, Sangstad at the time, and I said, you want to use this before the cat gets out of the bag, the horse gets out of the barn, before the immune system gets stimulated. So let's use it for induction. And they said, okay, but they had the drug. I didn't. So I was a shill for the company because they gave me the drug and they gave WashU $25,000. But this has been made my career. So it finally got approved after 20 years. But based on the work that I did, a randomized double-blind placebo-controlled trial, it was approved around the world for use as an induction agent. And now it's used in over 70% of people in the United States as an induction agent. The other thing with CMV, when I started doing this, there was no drug for CMV, okay? Then they came up with DHPG. That was intravenous ganciclovir. But to prove it, use it, you had to show they had retinitis. So then they came up with this new thing. It's called polymerase chain reaction, PCR. Shows you how old I am. So I came to WashU and said, let's do this trial because they were given IV ganciclovir for 21 days, and all it did was delay the CMV. So let's do the preemptive treatment, let them get a little bit of CMV and then come and rescue them before it gets out of control. And I think actually stimulating the immune system will allow them to do better. And sure enough, it did. And a friend of mine, Majit Lemay, who just recently moved from Washington University, University of Washington. I get those confused. And so went and he did this trial called the capsule study showing that preemptive is the best thing for liver transplants. I thought that I had proved this years ago, but apparently I hadn't. And the NIH thought so too. So they're funding a big thing. So the bookends on my career are going to be CMV for the prevention as preemptive treatment for the prevention of the disease and in renal transplant patients. Preemptive treatment for BK, just used what I used before. There's a reason CMV and BK are called opportunistic infections. They take the opportunity of having too much immune suppression. I think as doctors, as transplant doctors, our world tries to give patients as much drug as they can tolerate. I have worked most of my life to provide the least amount of drug that's effective. And that takes some courage and partnership with your patient. Then the use of cell-free DNA. Again, this came, I thought, you want to have your drug succeed, have me think it'll never work. That's the key to success, because things I've thought worked didn't, things I didn't think worked did. And so I've done some studies just for the fun of it. So I've participated in vascular composite allograft of the scalp islet transplants, vascularized composite allograft of the penis and lower abdomen at Hopkins, use of checkpoint inhibitors in renal transplant patients with cancer, and immunosuppression minimization with stem cell. And I'll just show you some of this. This is a patient, Mr. Cook. So I can say his name. He's dead. I got this. It got accepted for publication before he died. He had an invasive squamous cell cancer, and he had no skin on top of his head. So working with the plastic surgeons, we did a cadaver or abdominal rectus transplant to his head to provide the vascular bed, did an auto skin transplant and revascularized from his neck. It worked. I didn't know how to judge rejection, so I made up my own based on the old heart. It was a muscle. Rejection criteria, and this is what we used. What happened, he ended up developing chronic rejection, but this big lump, and that my plastic surgeon, Tim Jones, I think he's still here in town, said about plastic surgery, I can make you look different. I'm not sure it'll make you look any better. But so this guy had this big lump on the top of his head. But as it rejected, it went right down, and then he had this, as you can see, right on the right side there, very smooth, pretty good result. Islet transplant, did a bunch of that. The longest surviving islet transplant person is something we did, was able to have erections, which he hadn't been able to after having an islet transplant. This is something, St. Louis, this is great. So Sherm Silber runs a fertility clinic out at St. Luke's. He came to me years ago and said, I want to do ovarian transplants. I said, you're going to have to do it in an identical twin if you don't get immune suppression. Maybe, because it's not vascularized. He did it, it worked. That's the New England Journal. Then he came back to me and said, I want to do this when they're not identical. So I had a 2 haplotype patient, and she had Turner's syndrome. She's in Israel. In Israel, he told me that it's hard to get married if you can't have children. Turner's syndrome can't. So he took a sister, ABO incompatible, and transplanted her. And then she started with a sliver of her sister's ovary. She started to menstruate. We submitted it to the New England Journal. Right now, my track record with the New England Journal is not very good. So they rejected it. So then she ended up conceiving. Maybe we should send it to the New England Journal. Nah, Sherm said wait. And then he just he decided he was going to send it into that oft-read journal, Fertility and Sterility. Not on my coffee table for sure, but of course, and that was after she delivered a healthy baby about a month and a half ago now. So I think I have a picture of that. This is the ovarian transplant. The white thing is a slit. This is showing ovarian hormones, something I never understood. And this is the baby, 40 weeks, 2 days, amazing. Pretty cool. Penis transplant came to Hopkins. One of the things I can tell you about Hopkins, they love to do research. And so I got part of this, part of the vascularized composite allograft group. And we had, this is a man who had an IED blew off his both legs, most of both legs. He's got a very high amputation and prostheses that he has, his penis, scrotum, and then his lower abdominal wall. They did this transplant, and I've been helping with the immune suppression. He's now got his MBA, looking for a job. Checkpoint inhibitors to treat cancer. Notice the first author, Tarek Al-Hamid. So this is an interesting story. I pretty good knowledge of the literature. The oncologists at WashU would come to me when they started someone on an agent. They didn't. They started someone on these new drugs, the checkpoint inhibitors, miracle drugs. Got the pembrolizumab, came back for the next cycle 3 weeks later, then went from 1 to 8. Called me up. What happened? Checkpoint inhibitors? I have to read about that. Whoa, this is a problem. They turn on the immune system, or they turn off the off switch. So it's a double negative. And we wrote this up. I sent it to New England Journal. Did I tell you about my track record? So it was rejected. And I was lividly resentful. So I said, are you crazy? People need to know about this, the transplant. So I immediately turned around. We sent it in to HAT. I think this was accepted within 24 hours. So it turns out when I went to Hopkins, or it turns out in April of that year, 2017, maybe 16, the New England Journal published a paper out of Hopkins looking at checkpoint inhibitors causing rejection in kidney transplant patients. It was by Evan Lipson. So then ours gets published in HAT the same month. I go to Hopkins, and Ed Krause, been there 40 years, says, Dan, you got to talk to Evan Lipson. We've got a beautiful thing now. We've got a beautiful relationship. He gets these NCI trials. I get no effort or money, but I help him do all the immune suppression for these people. And we're figuring out, mostly it's like Edison. I've figured out 1,000 ways how not to do a light bulb, make a bulb. And this is showing how we use cell-free DNA to monitor to know when you need to rescue. This is looking at our checkpoint inhibitor data. Just say it's changed. Oh, this is a patient. Look at that. Whoa. This is one of the patients. He's gotten so much better. And now we're running out of time. I just want to spend a little bit of time on this. When I started transplant, I was told the holy grail is to get tolerance, immunosuppression or transplant without immunosuppression. Sorry. And so we did it. So 20-person trial, 75% got off immune suppression. Takes a village to do this stuff. There's some people that you know. It takes long-term mentorship and collaboration. It takes a loving and supportive family. It takes a loving God. The group I'm with, this was from out of Sardinia, best rainbow I've ever seen. And there's still a need for the triple threat. Be willing and available to work nights and weekends. Take the high road, keep the patient in mind, believe in yourself, and above all, have fun. Thanks a lot.